Self-referral has been a concern since the 1980s. The concern relates to the financial incentives providers have to refer patients to themselves for additional services, including imaging. Specifically, this occurs when providers refer patients to an imaging facility in which they have a financial interest. As a result, self-referral may lead to unnecessary radiation exposure and overutilization of imaging. Stark laws beginning in 1989 were enacted to curb self-referral. These laws included an in-office exception for ancillary services if they are performed using equipment located in the same building as the provider's office. Studies have found that Stark laws have largely been ineffective in achieving their aim, as imaging self-referral rates were similar before and after enactment. Although self-referral has been studied extensively, less scrutiny has been given to a related phenomenon, the interpretation of imaging study by the same provider who ordered it, a practice we describe as imaging self-interpretation. Beyond concerns about unnecessary radiation exposure and overutilization, imaging self-interpretation is problematic when the interpreting provider is not well trained in interpretation. Interpretation by non-radiologists represents an important patient care issue, as these specialists, aside from cardiology, generally lack rigorous comprehensive imaging interpretation training provided during a 4-year radiology residency. Some specialties provide limited, targeted imaging interpretation training, such as ultrasound for emergency medicine or obstetrics and gynecology. However, such training varies widely across programs. This variability contributes to reports of graduating residents lacking confidence in interpretation. Interpretation training in non-radiology residency programs may also occur informally, such as through rotations in radiology, but even then, residents typically engage in imaging interpretation only passively. Non-physician practitioners also interpret imaging, yet they receive almost no formal training. One study found that 25% of non-physician practitioners received no imaging interpretation training at all, and 98% received at most 2 days. The aim of our study was to evaluate the frequency of imaging self-interpretation of office-based diagnostic imaging by the ordering provider and to assess its association with provider and practice characteristics. In our study of more than 1.6 million office-based imaging studies, 43.6% were self-interpreted by a non-radiologist ordering provider. This percentage varied by modality. It was 50.4% for X-ray, 52% for ultrasound, 5.3% for CT, 6.1% for MRI. By specialty, primary care physicians self-interpret 19.9% of studies, mostly X-ray and ultrasound. Non-physician practitioners self-interpreted 30.5%, predominantly X-ray. Results from our logistic regression analysis, which control for provider and practice characteristics, indicated that the odds of imaging self-interpretation were higher for males, varied by ordering provider's age, and were lower in larger practices. Notably, the odds of imaging self-interpretation were roughly half when a radiologist was present in the ordering provider's practice. This may suggest that ongoing healthcare consolidation could reduce imaging self-interpretation by increasing access to a radiologist within the practice.